Good afternoon. This is Harsh Srivastava, and my seminar topic is surgical management of postpartum hemorrhage. And this is what we will be discussing over the next few minutes. So let's proceed. I think let's proceed with a case scenario. So a 29-year-old woman comes to you. She's gravid 2, party 1, abortion 0, live birth 1, and she underwent an elective cesarean delivery at the gestational age of 37 weeks for for a complete placenta previa in this in our obstetric department. So during the procedure, the placenta was delivered manually without any difficulty. There was no evidence of placenta acquita. Prophylactic oxytocin was given to prevent uterine atony, and hemostasis was achieved, and the uteri did contract. It was well contracted. But however, 2 hours after the surgery, heavy vaginal bleeding started, and so to control that, 10 units of oxytocin were given, and 1,000 microgram of misoprostol per rectum was given, and also the uterus was manually compressed. Yet the uterus started bleeding again after 2 hours. So curettage was done, and it was revealed that there was no retained placental tissues. So the clinical picture was compatible with atonic uterus. What will be the next steps of management? And this is basically what I'll be discussing in this seminar. Because what is to be done when the medical management fails, and that is the surgical management of postpartum hemorrhage. So to just have a brief overview of the surgical techniques that we can do. So, and these are in an order, in a chronological order. What is done first is written before. So uterine packing can be done, balloon tamponade can be done, uterine compression sutures are available, uterine artery ligation can be done, internal iliac artery ligation, arterial embolization, hysterectomy, and pelvic umbrella pack. So we will be going over these one by one. So let's start with uterine packing. So all of us know what packing is and how do we pack. So first we need a ribbon gauze, and for uterine packing, we would need a gauze which is 5 meter long and 8 centimeter long, and it has to be soaked in antibiotic. And what we do is we place it high up the fundus, and after that we pack the rest of the uterus. That is the way we do it. And vagina is packed with a different gauze, not with the same one. After the uterus has been packed, we give the lady some antibiotics, and the plug is removed, pack is removed after 24 hours. So what is the principle of it? What it does is when you insert a pack, it stimulates the uterine contraction. That is one. Second is it exerts direct hemostatic pressure on the open sinuses, which is known as the tamponading effect. So it is a dual mechanism by which the bleeding is stopped. But important thing is this has to be done under general anesthesia, right? And this is the first step that is done whenever the medical management fails. And what is important is like many cases of PPH, if it has happened in a primary center, so and if that cannot be controlled there, so while transporting the patient to the tertiary care center, the patient can be packed, and then the patient is sent to the tertiary care center for further management. Another, so this is, you can see, this is the pack that has been inserted, and this is soaked in antibiotics, and this is removed after 24 hours. So next we come to balloon tamponade. Now there are various ways to achieve balloon tamponading. We have Buckley balloon, which is specifically for uterus, but we have also other um, other ways which are used for different purposes, like Foley catheter, condom catheter, Seng's taken Decamer tube. So these all can be used. However, Buckley balloon is the preferred one. The capacity that is required for them is ranges from 200 to 500 ml, and that is why Foley catheter can prove insufficient because the capacity is not as much. So that is why we do not prefer Foley catheter. So what we do is first we insert it into the uterus, and after insertion we inflate it with normal saline. Now whatever is whatever amount is required between 200 to 500 ml, we inflate it with it, and we take it out in 4 to 6 hours, or if the bleeding stops. So the principle happens to be the same as uterine packing. There is, the same. It stimulates the uterine contractions, and also it exerts direct hemostatic pressure. And this is the preferred method now, and not the uterine packing, simply because it's much easier to use, much less cumbersome, and achieves the same effect. And that is why it is now the first surgical intervention for most women with 820 PPH. And if done at the right time, this can save hysterectomy in 78% cases, which is a huge number. So this is the Buckley balloon catheter. You can see here the syringe which injects normal saline through a tube. The tube goes inside the uterus, and here the balloon is inflated. And once it is inflated, it is exerting this hemostatic pressure or tamponading it, which reduces the bleeding. Next, we come to the uterine compression sutures. If the bleeding is not stopping that way, then there are certain sutures that we can apply which compress the uterus. Now, there are dozens of sutures that can be applied. I'll only be discussing the most important ones. So, some of these are Balian suture, Hayman suture, Koskar, hemostatic suture, and the Hackle suture. Let us start with the Balian suture, which was actually the first compression suture to be developed. It was developed by Christopher B. Lynch in 1997. So what is done is it is done in open uterus, like if the uterus has been open in following a cesarean section, but if not, the uterus has to be open via an financial incision to be able to put a Balian suture. And what the suture does is it compresses the upper segment of the uterus while leaving the lower segment. And for the suture, we require the number 2 chromic catgut suture. Before applying the suture, we do bimanual compression, right? Just to say if the Balian suturing will be successful or not, we first check it via the bimanual compression if some improvement can be seen or not. It is also referred to as brace sutures because these sutures sort of brace the uterus, like you can compare it with a school bag, how the straps brace you over the shoulders, and that is how these Balian sutures are. And the principle is, since it is a compression suture, the principle would be it has a tamponading effect, and that is how it stops the bleeding. So the success rate is about 80%, and which can avoid hysterectomy. So you can see the Balian suture. We insert the needle from over here below the financial incision through the anterior wall. We take it out, and then we go through we bring it out above this incision. Then from the anterior wall, we bring it out and take it behind the uterus. And then we go posteriorly, and we bring it out from the posterior wall. Then we go to the other side, again pierce the posterior wall. Then we go posteriorly and come back anteriorly. And then above the phalangeal incision and below the phalangeal incision. And this is what the final result looks like. And you can see here it braces the fundus of the uterus and the brace suture. Next is Hayman suture. So Hayman et al. Realized that there are certain problems with the Balian suture. A few of those are like hysterectomy is necessary. Either the patient should already have that incision after the cesarean, or you have to give that incision. Also, because PPH is such a emergency condition, it's sort of difficult to remember all those steps during an emergency. So a faster way was required, and that is how Hayman and colleagues developed this method. One of the things you can see is because it's like it braces you over the shoulders, so just like a school bag, how easy it is to just slide off your shoulders. Similarly, these sutures may just simply slide off the uterus, and that might create a problem later. So in Hayman sutures, the uterine compression is achieved by using 2 longitudinal threads which transfix the entire uterine wall. How is it done? What is in the needle transfixes the whole thickness of the both uterine walls, like the anterior wall and the posterior wall at the lower uterine segment level, and the thread then is passed over the fundus so that it compresses it, and it is tied at the fundus, which is the important thing. It is also referred to as simple brace suture because Balian is base suture, and it is a simpler form of Balian, so it is regarded as simple brace suture. And the suture uses a number 2 polyglycolic acid, suture or the vicral suture. How we do it is simply we in the lower uterine segment, we go from we insert over here, go to the posterior wall and bring it out through the posteriorly, and we tie it over the fundus. And same thing is done over here. Same thing is done on the other side. Next, we go to the co-square hemostatic suture. So, what Coe et al. Stated that the purpose of the technique is to approximate the uterine walls until no space is left in the uterine cavity. Because these sutures are very tight, and that is the principle that such tight sutures are placed that there is no room for bleeding is left. So how it is done is a needle transfixes the uterus from anterior to posterior from point A to point B, and then from point C to point D. All of this is done in a square manner. Like these points A, B, C, and D, these are points of a square. A, B, C, and D. And that is how we go. First anterior, then posterior, then anterior, then posterior. That is how a square is formed. So in an 820 Q square, 4 to 5 square sutures have to be made usually. And although these co-square sutures are easier than Boolean suture, one of the drawbacks is these sutures are so tight and that they compress the uterus both horizontally and vertically because it's a square, right? And if a square is tight from all four sides, it's compressing that segment both vertically and horizontally. It totally cuts off the blood supply and it may lead to ischemic necrosis and subsequent complications. It is a big drawback. It is also referred to as multiple square sutures because multiple squares and a number one chromic cadaveric sutures are used. Let's see how do we make it. At point A, we insert the needle in the anterior wall and then we bring it out from the posterior end. At point A, we cross the both wall, the anterior and the posterior. Then we go to the other side, and then from the posterior end, we again bring it out to the both walls, to the posterior and anterior wall, and bring it out at B. Then at C, we again insert a needle, and it crosses both the anterior and posterior wall, and bring it out. And then it crosses to the other side to the point D, and from the posterior wall, again we insert it, and it crosses both the walls, both the walls, posterior and anterior walls, to come out. And that is how these squares are formed. Next, the last one among the compression sutures that I'll be discussing are the Hackettle sutures. So these are 6 to 16 transverse sutures and 2 to 4 centimeter long U sutures that are made. And it's important to know why the advantage of these sutures are like in the co-square sutures, because they were simultaneously horizontal and vertical compression. The blood supply was getting cut off, but because these are just transverse or sort of U shape, so there is no simultaneous vertical and horizontal compression, and so that complication of ischemia does not arise. And that is why. And another thing you see is 6 to 16 transverse sutures. These are the highest number of sutures that you have seen until now. So Hackettle et al. Claimed that multiple sutures may provide insurance in case one of the sutures loosens, just as an insurance. And it is referred to as multiple transverse U sutures. And number 0 vital sutures are used. How they are done, you can say it. This is the posterior view, how it looks like. You come from the anterior view, and the needle comes out posteriorly, then goes to the other side, then you come out. So this from the posterior end, it looks transverse, and it comes out anteriorly. Here it is tight, but if you see it 3D, it's U-shaped both, and if you see it both anteriorly and posteriorly, and hence the name. Then we come to the ligation techniques. If the compression sutures are not working, to understand like your dad has asked you to garden to water your garden, and the pipe is leaking a lot. You try to compress it here and over here, so that somehow you can still manage to do it. But if still can't do it, what you try to do? You just go back and just close the tap. This is sort of the principle. If compressions do not work, we start ligating the arteries. That is the source of bleeding, where the blood is actually coming from. So in the uterine artery ligation is the first artery that we try to ligate at the lowest level. So the ascending branch of the uterine artery is ligated, at the lower border, and where at the junction of the upper uterine segment and the lower uterine segment, that is where we ligate the uterine artery. And what you have to see is this suture. This is passed medially into the in medially into the myometrium, and that's how the artery is tied. This is how this ligation is done. In case the ascending artery, uterine artery ligation is unable to stop the bleeding, we can also then we try uh, ligating it by the same technique at the anastomosis of uterine artery and the ovarian artery. For this, we use the number one chromic suture, and if in an A20 PPH, if bilaterally it is done, it is sort of effective in a 75% of cases. If bleeding is still not controlled, what is above uterine artery? We have the internal iliac artery. So we ligate the anterior division of internal iliac artery, which is very important. We do not do it for the posterior division. We do not want to cause ischemia. We just want to control it over the uterus. So ischemia in the pelvis. So we just compress the anterior division. So how do we do this? Once we reach the iliac artery by dissecting other structures, the areolar sheet is dissected by a longitudinal incision, and we place a clamp over the artery. But what's important is it is placed from lateral to medial side, which is important. This is done to save the internal iliac vein, because if we damage it, a whole new source of bleeding is created, which is difficult to control. So, which is what is written, where care must be taken not to perforate the contiguous large veins, especially the internal iliac vein. And for this, we use non-absorbable sutures. And the mechanism of action, like how it works is, when you compress the anterior division of internal iliac artery with a clamp, there is an 85% reduction in the pulse pressure. We know arteries have in arteries blood flows in such high pressure, and it is iliac artery is a major artery, so you can imagine the pressure in it. So after clamping, the pressure is equivalent to a vein, and because of that, clot formation is facilitated, and that is how it works. So, and if we bilaterally ligate the anterior divisions, we can avoid hysterectomy in half the patients. It's not too much, but it is not very less as well. It's significant. So you can see here we have the common iliac artery dividing into external iliac and the internal iliac. The internal iliac divides into the anterior division and the posterior division. We don't ligate the posterior division, we ligate the anterior division. You can see it over here. How laterally to medially it is the clamp. See, laterally to medially, right? And that is how this stops. You can see here also this is the common iliac, external iliac, internal iliac, posterior division, anterior division. Here it is ligated, and to reach the stage of internal iliac ligation, it means that your uterine artery ligation hasn't worked. So you can see the clamps, the ligatures over here as well. Next, if this surgical access to vessels, if that is not possible or that is very difficult, is associated with many difficulties, another thing that can be done is selective angiographic arterial embolization. If the technique is available at your institute, this is something that can be done. So embolization is done using gel foam, because embolization means that the blood flow will be obstructed. That is how it prevents the bleeding. And how is this embolization monitored? It is through fluoroscopy. Now the success rate is very high. It's more than 90%, and it does avoid hysterectomy. Also, the fertility is not impaired, and most women have successful subsequent pregnancies, but it's usually not done as the first thing, because of embolization, ischemic necrosis may happen as a complication. So what it looks like, you can see here we have these pelvic arteries, and after the dye was injected, you can see in the arteries the dye is present, but the dye has also leaked over these sites where the bleeding is present. You can see, and this was the early picture. If we take it after the time the dye has passed away from the system, you can see that the dye is present only at the bleeding sites. That is how we can visualize it. And once the embolization is done, you see after embolization, when the dye is injected again, now there is no leakage. So this is how it works. So everything fails. You've done everything. You did your medical management. You did the packing or all the tamponading. You tried the compression sutures, did not work. You ligated the uterine artery, the uterovarian anastomosis. You ligated the anterior division iliac artery. It still did not work. You have no other way but to do hysterectomy. So if all the measures fails, hysterectomy is done. But a second obstetrician should be consulted for it. Now, it could be subtotal or could be total. It depends on the need of the patient. It depends on the case. What usually is done is first we do subtotal and we see if the bleeding has stopped or not. If it is controlled well and good, if it's still bleeding, we can proceed to doing total hysterectomy. Total cervix is also removed, right? But you have even removed the uterus, and you are so unfortunate that even now the bleeding hasn't stopped. What do you do? So, in 1926, Lockett Applause, he had described this, like this. He had developed this umbrella or parachute pack. This is placed when the pelvic hemorrhage still keeps happening despite the hysterectomy. So, what it does is it stops the bleeding by tamponading and traction method. So it's simply a plastic bag that fills that cavity that has been created after the uterus has been removed, and it exerts pressure over there. This is what it consists of. It is a pack which consists of a sterile X-ray cassette bag filled with gauze rolls knotted together to provide enough volume to fill the pelvis. That's how we stop the bleeding. The pack is introduced transabdominally, obviously, after you will remove the uterus, so you will introduce it transabdominally with the stalk that exists the vagina. Why does the stalk exist the vagina? One is to remove it, and second, through this existing stalk, we apply traction through a weight. So mild traction is applied, tying the stalk to a 1 liter fluid bag, which is hung over the foot of the bed. Now we also give broad spectrum antimicrobials, and it is removed vaginally only after 24 hours. And this is the last ditch attempt, because after that you cannot do anything. You have literally done everything that is known to medical science right now. And what does this pelvic umbrella pack look like? This is the ring. This this is the plastic bag, and under it is this gauze. This is all rolled up and placed inside it. So, and this is the end that will lie out of the vagina, and it is connected to this tubing and this 1 liter bag. It has the dual purpose. It sends the fluid inside to inflate it, and this 1 liter bag will exert the weight to apply the traction. So that is all the techniques that we needed to know, which come under the surgical management of postpartum hemorrhage. And these are the resources which I use to prepare these slides, which mostly include Williams, Datta, and few good review papers. So thank you so much.